Hi everyone, this is my choice for the most interesting literature for the first week of this year, January 2021. I hope you like it. So, for this week, I've chosen an engaging article that's published in the Journal of the American Heart Association termed the Global FFR. And if you are interested in coronary physiology like me, then you know about the FFR, of course. But to me, the concept of global FFR was new. That's why I chose this article. And of course, you know the FAME study, the FAME 1 and the FAME 2, and it's making a coming back through this study on global FFR, published in the Journal of the American Heart Association, and the link to the full text will be available in the description below. So the title of the article is Global FFR Predicts the 5-Year Outcomes in Patients Without Ischemia. And what really grasped my attention is the word global FFR and the word without ischemia. So what does global FFR mean? The authors of this article, they were more the same authors of the landmark studies of FAME 1 and FAME 2 that established FFR as a benchmark in managing stable ischemic heart disease as the cutoff of 0.8. And you know, of course, the FAME 1 study 2009 that showed superiority of FFR guidance over angiography guidance. The FAME 2 in 2012 that showed superiority of FFR guided PCI over medical therapy alone in patients with chronic stable angina, taking a cutoff value of 0.8 or less to be revascularized. More than 0.8 can be managed medically well. These patients were included in a registry. So what the authors of this study on global FFR did is that they took patients from the FFR group of FAME 1 and FFR group of FAME 2 and patients in the registry. So they took patients when their FFR values have been more than 0.8, whether they have been stented or the vessel has no significant disease or mild disease with an FFR value of more than 0.8. So they took non-ischemic patients by our cutoff of 0.8 and they did a global calculation of FFR. Global here means summing up the FFR for the three major coronaries, taking the post-PCI value of 0.9 and taking 1 as the value for a normal vessel. So they excluded anyone with an FFR value of 0.8 or less. They only included patients above 0.8 and they sum up their FFR values. So taking, for example, this patient with a value of FFR identity of 0.9, circumflex 0.87, RCA 0.87, the global FFR for this patient would be 2.66, and the value of the global FFR in this study would logically range between 2.43 and 3.0. And what they did is that they looked at the three tertiles of global FFR in all the vessels that are not ischemic by definition, and they checked how did they correlate with the 5-year major outcomes, and compared that to the angiographic extent of disease. When the number of lesions more than 50%, how did that compare with the 5-year MACE? And no surprise, they found that the visual assessment didn't have any correlation with the long-term outcome. Whether it's single vessel or more than one vessel disease, there was no correlation. Whereas when they calculated the global FFR, they divided it into three tertiles. The lowest tertile with the global FFR less than 2.8, the middle between 2.8 and 2.88, and the highest is more than 2.88. And what they found is that patients with a lower global FFR had on average 30% more MACE events than patients with high global FFR. And they concluded that patients with a low global FFR that global FFR can be an independent predictor on the occurrence of MACE. If we look at the individual endpoints, MI was significant, revascularization was even more significant, whereas death as an endpoint alone was not significant. And the authors concluded that an increase of just 0.1 in the global FFR was associated with a statistically significant reduction in the number of major adverse cardiac events. So how would this change the way we think or the way we practice? The first change is taking a single cutoff of FFR is more of simplistic. We use FFR in a dichotomous way in clinical practice. However, it's more wise to think of FFR as a dose-effect relationship. We know from other studies that even higher than a value of 0.8 still carries a dose-related relationship, which means that 0.9 is better than 0.8 and 1 is better than 0.9, and this has been shown in more than one study. So this is the first point to consider. The second point to consider is that patients with some impairment in their FFR, they can still do bad on the long-term outcome. This has many explanations. We know from other literature that focal lesions with 0.06 drop in FFR are associated with further plaque ruptures. We can also use this study to think of the concept of summing up FFR in the individual coronaries and trying to use that for risk stratification. We can do that from coronary CT scan or from conventional angiography. And maybe when we find a patient with low global FFR, this would make us more towards aggressive risk factor management. So I would welcome your comment and feedback. Would you do FFR for all three vessels? Would you sum up the FFR and use it to risk stratify? And would you keep in mind that really 0.9 is better than 0.8 and 1 is better than 0.9? Please write your comments below, and if you like the content, please subscribe. See you next week.